Education usually kind of kick-starts that off, because that's when it starts. So we can be invited to all the ESCO meetings and things in that. So we're kind of involved at that stage as well, aren't we, to try and ensure a smooth transition process.
Yeah, so we would take children and young people up to the age of 25, depending on their level of need and what is appropriate for them. Now, transition, I think, is an area probably nationally that needs to improve. It should happen at 14, maybe earlier, depending on the competence of that child and their knowledge base. And those conversations should start early. Now, that needs to start in all areas. So that needs to start in the hospital settings. It needs to be starting in the hospice setting. But what we're finding is there's often a gap. So for some of these children with very complex needs, that transition is incredibly difficult because there is a gap where there is lack of service. We find that from paediatrics that there's this very nurturing, family orientated feel to the services that we provide, and then that transition into adults is such a difference, and not that it's not nurturing or caring, but it's a lot more independent. And you go from a huge level of support as a family holistically to an adult journey that is very focused around that young person, and that can be incredibly tough on the families, as well as then lack of services that are at that sort of late adolescent years, which I think is very difficult for families.
So if we're actively involved with the child, and we're not actively involved with all children that have a palliative diagnosis, but if we are actively involved with the child, then we will work with the families and try and aid that transition and work with the adult practitioners as well. We had a young lady that had an oncology diagnosis, and she was just coming up to 18, so we actually kept her on until she was 19, and we looked at doing joint care with the adult service and supporting that transition over, and we would support wherever we can, really.
And is that a difficult time for the child to make that transition?
It can be, because it depends on the needs of the child, but the complex children, as a community children's nursing team, we kind of do a bit of everything. So if they've got a Mickey button, we'll look after that. If they've got a tracheostomy, we'll look after that. Whereas when they go over to adults, it's a bit more, they have a different consultant for the different things, and it's sometimes the families find it harder to coordinate, and that's why they sometimes ask for help as well.
Hospice care for what we deliver is quite different to what the hospice care is in an adult environment.
So it's not always appropriate, is it?
So who makes the decision as to when that transition takes place?
It can be anybody's decision. We should be working with them from that. It could be us as a hospice that we're trying to initiate those talks sooner. It can be that from a medical perspective that a consultant may liaise on that element of care, that they're recognising that, that they're getting to a point that this care is going to be transferred over. It may be that from a hospice perspective where that little bit later than maybe the medical side of things. In areas that I've previously worked, we've had transition leads. So within the hospitals, we've had a transition worker. Here, what we have at a hospice is we're trying to establish like a transition link, so a link role. So we've got those people that take that interest in transition and can keep their eye on those children that we need to start thinking about transition in their care.
And it's kind of a handover process, isn't it? It's not like one day you're accessing the paediatric service and then the next weekend you're accessing the adult service. There's a lot of liaison between us and adult services here, and we'll usually support the the young person, don't we? Initially, so that there's like that gap is kind of bridged, and then it's kind of a gradual kind of handover, isn't it, really? So it's not, like I say, it's not just one day you know, somebody's going to wake up and, well, you're not actually coming here anymore, you know, so you're an adult now, so.
Do you think it's important that transition takes place, that the young person has to start to feel more independent, and that, is that an important part of their journey?
Definitely. If they're able, then yes, certainly, then we should be encouraging that. Obviously, there are the young people that access that's not going to happen for them, but it's about making sure that they know who those professionals may be that they will be going to. It's the services that are available to them and making them aware of those things. It's thinking about long term, obviously, if they can't communicate for themselves or if they've not got capacity, once they hit that age of, we need to legally be having parents, you know, who is that person going to be that advocates for that child, and putting processes in place for that, and making sure that they're done, and not just assuming that they've not got a voice.
Young people with life-limiting conditions, as you can imagine, they've been very protected by the family unit or whatever, and clinicians and everything else, and it's about encouraging them to grow, to say, you know, you getting older, you have got a voice. You need to be kind of proactive in thinking about these decisions that you want to make for yourself. So a lot of that can be quite tricky, can't it? Especially for parents, just to kind of just step back, but we're always mindful that we need to kind of promote this self-advocacy.